for another 30 seconds so that people can join and then
Sure.
we'll...
Sure.
3, 2, 1. We are live now, ma'am.
Good evening, ladies and gentlemen. Welcome to another exciting and enriching episode of Blood, the Life Savior. And a warm welcome to our contributors from Madras Medical College, Chennai. And today we have another interesting topic, transplant, turning tide in hemolysis with dysplasia. And we assure you this 1 hour is going to be enriching for all of us. All this has been possible because of untiring effort of our program directors. Warm welcome to our course directors, Dr. Biju George, and we know him very, very well. He is professor at Department of Clinical Hematology at CMC Hospital, Vellore. Many contributions to the field of hematology, and as a clinician of great level. We know him because close to 300 publications in all Scopus Index journals. He developed the fludarabine and cyclophosphamide conditioning protocol for aplastic anemia, which is followed by all of us. He's been invited over 200 plus haploidentical transplants at CMC Vellore. So many families are thankful to him, and he has developed specialized transplant protocols for Fanconi anemia and other congenital disorders. Dr. Biju George's areas of interest continues to be stem cell transplantation and infection management and bone marrow failure disorders, cognitive and acquired. Our second course director, Dr. Joseph John, we know him equally well, professor and head department of clinical hematology at CMC Hospital, Ludhiana. More than 30 plus international and 38 national publications, contributions to 7 book chapters, principal investigator in more than 20 plus clinical trials, many awards and accolades to Sir's credit, but he has also contributed in creating an institute par excellence in northern part of India in Department of Hematology. He established clinical hematology department and stem cell transplant services at CMC Ludhiana. And then he founded Comprehensive Hemophilia Care Center and later a Center of Excellence in the same department, pioneered first successful stem cell transplant for leukemia in Punjab, and also launched DM program in clinical hematology and innovative services like home care and mobile management phlebotomy. May I request Dr. Joseph John and Dr. Biju George to introduce our participants today.
Thank you,
Thank
Manoj.
you. Yeah,
Go ahead.
Joseph.
Okay, so today we have from Madras Medical College a team presenting to us on transplant in PNH, and we're looking forward to hearing from them. We have Dr. Aruna Rajendran, who's the professor and head of the department, and she has immense experience and recently won an ICMR project for Center of Excellence in research. And she has a lot of publications and experience, and she has traveled across the world in gaining additional experience. I would request Dr. Aruna to actually introduce your team, Karthik and Lakshmi, so that they can start the presentation following that.
Thank you, sir. So, it's my pleasure to introduce the panelist and the speaker for today. So, Dr. Karthik Velavan is our assistant professor in the Department of Hematology at Madras Medical College. He has completed his DM, clinical hematology from AIIMS Bhubaneswar, and he has also worked in ESI hospital, and he is a consultant in a private hospital, Viha Hospital, and in Kaveri, Chennai. So our speaker for today, the case will be presented by Dr. Lakshmi Chitra, who is our DM Senior Resident in Department of Clinical Hematology at Madras Medical College.
You can put your slides, please, and start.
Lakshmi ma'am, you can share your slide.
Can you see my screen?
No, ma'am, you need to share, put on the share screen at the bottom. You can see the share screen.
It's coming. Put it on the PowerPoint mode, please.
Yes, sir. Is it visible, sir?
Absolutely. Please go ahead. We can hear you also well. All the best.
Okay, thank you, sir. Good evening to all. Today I'm going to present about the bone marrow transplant for a PNH in the era of eculizumab. I'm a DM senior resident in Madras Medical College. It's an ICMR Center for Advanced Research in BMT. Case summary. First, I will describe the case summary. It's a 32-year-old female who is a known diabetic, was apparently normal till 18 years of age. In March 2010, she had a history of menorrhagia for 20 days in a month, which is with the passage of clots. And she had a history of fatigue and tiredness. So she visited a nearby hospital. So they have done an CBC, which showed an HP of 5.3 gram per deciliter, total WBC count of 2019, and platelets was 9,000. And the peripheral smear was reported as in pancytopenia. Her renal and liver function test, all the parameters were normal. So the autoimmune screening of A&E was negative, and DCT, ICT were negative. The USG abdomen showed a normal study. There is no organomegaly. And from the nearby hospital, they have referred her to a private medical college. In April 2010, the CBC, which is done in the private college, showed an HP of 7.3, total count of 5,600, and platelets was 17,000. She had a bicytopenia with a retic of 4.3%. And the bone marrow biopsy, there she underwent a bone marrow biopsy and the aspiration. The biopsy showed a varying cellularity with a megaloblastoid erythroid maturation and adequate myeloid, and the markedly decreased X was seen. And she's been diagnosed as an PNH in that college, but the record was not available with the patient. And there they have started her on cyclosporin, and she was in cyclosporin from 2010 to 19. During this period, she had 3 to 4 units of blood transfusion per year. In 2020 to 22, she discontinued that cyclosporin and because of COVID pandemic, and she has been transfused 2 to 3 PRBC once in 3 months. So in 2023, she's been approached a private hospital again. There they have she has underwent a second time of bone marrow biopsy. It revealed an hypercellular marrow with an erythroid hyperplasia and dysmegakaryopoiesis, no increase in blast count. And karyotype was normal, and the PNH flow cytometry showed an RBC where the type showed a type 3 of 8.5% clone, monocytes of 89.6%, and granulocytes showed a 94.5% of clones. So she's been diagnosed as in PNH, and the NGS done for the hereditary cancer and MDS panel, which was negative. In 2023, after that, she's been referred to MMC for further treatment. On presentation, patient had a history of AC fatigability, shortness of breath for 1 week, and then red color urine for 2 days. She had this repeated history of yellowish discoloration of sclera and AC fatigability, and then red color urine for 8 years. So there is no history of any thrombotic events in the past. There's no significant family history. Her bowel and bladder habits were normal. And general physical examination, she had a pallor and an icterus. Systemic examination was normal, and per-abdomen was soft and there is no organomegaly. In MMC, we have started her on danazole. And still, the patient required 3 units of PRBC each month. So the patient had a persistent hemolysis with an ongoing transfusion dependence and a dysmegakaryopoiesis in the bone marrow. The patient and the family members were counseled for the bone marrow transplant. And she had an HLA match of 12/12 with her elder brother. So the patient underwent an allogenic MSD HSCT in November 2024. So these are her serial CBC, which showed initially she had an bicytopenia of anemia and the thrombocytopenia. And later it has been improved when she is started on cyclosporin in that private medical college. And after that, she had only an anemia with an hemolytic picture. Then in conditioning regimen we have given during the transplant was ATG, flu and trio. So rabbit ATG was given from days -7 to -5 or total dose of 225 mg given for 3 days. And day -5 to day -2 she's given an fludarabine of 50 mg per day for 4 days. And from day -4 to -2 she's given triosulfan of 15 gram per day for 3 days. And GVHD prophylaxis she received was injection methotrexate only in day +1 of 20 mg. Then the patient developed a grade 3 oral mucositis, so that she didn't receive a methotrexate of the day +3, 6 and 11. So we have started her on MMF along with the cyclosporin. The post-BMT issues were she had developed the grade 2 oral GVHD, and she had also had a menorrhagia with the clots for 15 days after 4 months of the transplant. For that, she was started her on OCPs. Then chimerism, which is done on date +30, 60, 90, and 180, showed 100% of donor chimerism. And the PNH flow cytometry post-transplant showed no phenotypic evidence of PNH. Now, the patient is on the tapering cyclosporin. So, this is the case. I completed the case history. Now, I'm going to talk about the PNH. So the introduction of the PNH is a rare acquired clonal hematopoietic stem cell disorder, which is characterized by the complement-mediated intravascular hemolysis, bone marrow failure, and then high risk of life-threatening thrombosis. It is mainly caused by a somatic mutation in the PICA gene. So there is a deficiency of GPA-anchored proteins, which is CD55 and 59. These GPA proteins, which protect the normal RBCs from the complement attack. So the incidence of this PNH was approximately 1 to 2 per million, which is prevalence of ranging from 10 to 20 per million. The subtypes, the 3 subtypes are there. One is a classical PNH. In this patient has an hemolysis and thrombosis without an evidence of a bone marrow failure. The PNH in the setting of another bone marrow disorder like aplastic anemia and MDS. Or subclinical, third one is a subclinical PNH, where the small PNH clone, which is detected by a flow cytometry without any clinical evidence of the hemolysis. The clonal risk in PNH. The risk of MDS and AML in a PNH is, which is very low, 3 to 10%. So the aplastic anemia patients, 50 to 60% may have an PNH clone. And the MDS who are a low risk MDS patient may have in 15 to 20% of cases have an PNH clone. So the PNH, which is evolving into an MDS or AML, usually they have an monosomy 7 or mutations in the A6L1, CEPP1, RUNX1, and the RAS pathways. So the PNH, the association mainly with a low risk MDS. With this low risk MDS, patient usually have a refractory anemia, but few patients may have a multilineage dysplasia also. So if they have the underlying bone marrow failure with the PNH clone usually will be small clones. They do not require a PNH directed therapy. So if there is any underlying bone marrow failure, the treatment should be directed on the underlying bone marrow failure which is present. So if the patient is an aplastic anemia, they should do a screening for PNH and yearly to see for the PNH clone size. So the management, depending on this severity of a cytopenia present, the age and the donor availability, and patients with an aplastic anemia, they should be taken up for the transplant or with an immunosuppressive therapy. So the patients in whom pharmacotherapy was failed can be taken up for the transplant. So the main drug which is used for this PNH is eculizumab, which is an anti-C5 monoclonal antibody, which is used for the treatment of PNH. It is a standard therapy for the PNH, which reduces the hemolysis, and it can also be used in patients with a recurrent thrombotic, decreased thrombotic events, and it also decreases the need for transfusions. And the glucosteroids, it reduces the severity of the hemolytic crisis in the PNH patients. The anticoagulation role, it can be given as a primary prophylaxis in high-risk patients with a large clone, high D-dimer levels in pregnancy, surgery, and the thrombophilia if the platelet count was more than 1 lakh. So the treatment in each subtypes of the PNHs, if it is a subclinical PNH clone, there is no specific therapy is needed. If they have the underlying bone marrow failure, the treatment should be focused on the underlying bone marrow, either it is an aplastic anemia or the MDS. So if it is in classic PNH, the treatment was eculizumab. If there is underlying bone marrow failure syndrome was present in the PNH, the significant clone was present, the patient can be benefit from the eculizumab. The emerging complement inhibitors in the PNH or anti-C5 monoclonal antibodies, that is eculizumab, ravulizumab, crovalimab, C3 inhibitor pegcetacoplan, factor B inhibitor eptacopan, factor D inhibitor danicopan. The eculizumab and ravulizumab, crovalimab, which blocks the terminal complement and it reduces only the intravascular hemolysis. It does not reduce the extravascular hemolysis. So the C3 inhibitor pegcetacoplan, the factor B and D inhibitor, these will help in the intravascular hemolysis. The C3 inhibitor, it controls both the intravascular and extravascular hemolysis. The factor B inhibitor eptacopan, which is an oral drug, which blocks the complement upstream of a C3. So it can be effective as a monotherapy both for the intravascular and extravascular hemolysis. This factor D inhibitor, the danicopan, which prevents the C3 convertase, it can be given as an add-on therapy with the C5 monoclonal antibodies in patients with the extravascular hemolysis to prevent the intravascular also. So this is a diagram, pictorial diagram, which describes the complement inhibitors which acts on the different levels. So the C5 monoclonal antibodies, that is eculizumab, ravulizumab, crovalimab, which acts on the terminal pathway, that is it is in C5. And the newer drug which is in developing phase was the pozelimab, which is also in C5 monoclonal antibody. Cimdisiran, it is in small interfering RNA, which is acts on the C5. In the proximal pathway, the drugs which are act on the pegcetacoplan, eptacopan, and the danicopan. So it prevents both the intravascular and the extravascular hemolysis. We will see the eculizumab, which is a helps in reducing the intravascular hemolysis and risk of thrombosis in the classic PNH. So what are the patients who are eligible for the eculizumab treatment? Or the patients with the hemolysis of LDH more than 1.5 times the upper limit of the normal, or which who have the following criteria like HB less than 7 or HB less than 10 gram per deciliter if at least 2 independent measurements in patients with the cardiac symptoms, if they have a thrombosis related to the PNH, or the complication which is associated with the hemolysis or the renal dysfunction and pulmonary hypertension, if the patient has any abdominal pain or dysphagia or any erectile dysfunction, or pregnancy was in previous pregnancy patients who have a previous history of gestational complications. So these are the patients who are eligible for the eculizumab treatment. So the dosage for the eculizumab was, usually it is given as for the adults, it is given as in 600 mg over 35 minutes infusion weekly for first 4 weeks. In 5th week, it is 900 mg. After then, for every 2 weeks once, 900 mg. So if the patient is treated with an eculizumab before starting the treatment, the patient should be vaccinated for the Neisseria meningitis 2 weeks before prior to the eculizumab. Each vial is 300 mg per 30 ml and it costs around 80,000 to 2 lakh for Indian money. So what are the limitations and the challenges in the eculizumab? It is a very expensive drug and it requires a lifelong therapy, and it does not eradicate any PNH clone, or it does not provide a complete cure. It is a limit, and it also has a limited availability in low and middle income countries like India. It has a life-threatening infections like Neisseria meningitis, and it is less effective in bone marrow failure or in patients with a recurrent thrombosis. Eculizumab is effective only for the hemolysis or with the newly diagnosed patients with a thrombosis. And the patients who should not receive the eculizumab or who have only a mild hemolysis or no hemolysis symptoms, patients who have a clone size of less than 30% with the normal clones or no hemolysis. If the patient has an aplastic or anemia or MDS, that is underlying bone marrow failure, or without any hemolysis or thrombosis, they should not receive the eculizumab. And it is not a curative. Then, if the patient is not found cure with the eculizumab, they should be taken up for the transplant, and is a very costly drug. So other therapies are more appropriate in this settings. When we have to stop an eculizumab in PNH, if the clone size get reduced to less than 30%, or any reduction in the RBC transfusion of less than 30% need after the 6 months of eculizumab. If there is any persistent hemolysis with a minimal HP improvement, and if there is any spontaneous remission with the eculizumab treatment, if the patient have a severe bone marrow failure, then the patient should be stops the treatment if they are not adherent to the treatment. Condition where the immunosuppressive therapy it is used in the PNH. So the PNH with a severe aplastic anemia, or the PNH with an hypoplastic MDS, or the PNH clone detected in an aplastic anemia without a hemolysis. So if the patient has PNH with a severe aplastic anemia, the patient will get benefited from the immunosuppressive therapy of ATG with the cyclosporin and eltrobopac, which is a standard immunosuppressive. This improves the marrow function and will stabilize the PNH clone size. If the patient with an hypoplastic MDS, in selected patient with this, the immunosuppressive therapy will be beneficial, does not affect the underlying clone size. If the patient, the PNH clone detected in aplastic anemia without hemolysis, even a small clone slice, they get benefit from the immunosuppressive therapy. So the immunosuppressive therapy in these cases should be directed to an underlying marrow failure, not on the PNH clone size. So if the patient with the PNH with the MDS, it is more common in the marrow failure MDS, especially the refractory anemia, usually have a better prognosis. It is often associated with the multiple PICA8 clones with the HLA-DR15, and they usually responds to the immunosuppressive therapy. If the PNH clone expands after this immunosuppressive therapy, they should be managed as a classical PNH. Still, the prognostic value of the PNH and MDS still remains a controversial. If the patient does not respond to the immunosuppressive therapy, then in severe cases, patient has to be taken up for the bone marrow transplant. So there are 2 studies are there. This Japanese study showed an even a small PNH clone, if it is present, it has a better prognosis. So it has a less risk of leukemia and a higher response to the immunosuppressive therapy. In NIH study, the low risk MDS, the PNH clone show a no clear link with an immunosuppressive therapy. There is no benefit with the survival of the patients. So overall, the PNH clones in the MDS remains to be a controversial and uncertain. So treatment algorithm, if the patient diagnosed with a PNH, determine the clinical forms, whether it is in a classic PNH or it is a PNH with an hypoplastic MDS, or the PNH with an aplastic anemia, or the aplastic anemia with a small PNH clone. So if it is in PNH, classic PNH or the PNH with an hypoplastic MDS, or PNH with an aplastic anemia, they have to be evaluated for after 3 months. If it is very severe, then they have the matched sibling donor. They have to be taken for transplant. And then if they are not eligible, if they does not have any sibling donor, then they have to be taken for the ATG, immunosuppressive therapy. So if a aplastic anemia with a small PNH clone, they should be treated as per the aplastic anemia. After the evaluation of 3 months, if it is less severe in PNH, we can be treated the patient as a supportive therapy with the transfusion or the immunosuppressive therapy. If it is stable, we can follow up the patient. If they have progressive disease with a PNH, they have to be taken for the transplant. When to do a transplant in the PNH? If the patient have a severe bone marrow failure or aplastic anemia, we have to taken for transplant. If the underlying clonal evolution, whether the patient is turned into an MDS or an acute leukemia, they have a refractory hemolysis, that is, they are transfusion dependent even after the complement inhibitors or immunosuppressive therapy, they have to be taken for the transplant. If they have a recurrent thrombosis even after the complement inhibitors, or the unavailability of the complement inhibitors. So these are the patients have to be taken for the transplant. So the regional variation, the ancient patients, they have predominantly have the bone marrow failure. So they are more often the transplant was indicated in this patient. In Western patient, predominantly of the thrombosis. So drawback of the transplant is primary cause of the mortality in the transplant is the GVHD and the infection. The challenges is high rejection risk due to the heavy transfusion burden and the alloimmunization. Because the day of diagnosis to the transplant, if it is more than 1 year, the patient will be heavily transfused, so they are more prone for any graft rejection. So the HCT outcomes, the two major study was there. One is EBMT data, which is in this total of 211 patients were taken. The study was done from 1978 to 2007, where the patient were diagnosed with a PNH taken up for the transplant. The 5-year overall survival was 68%. So according to the donor type, whether it is a sibling or the unrelated donor, there's no major difference was seen. And the transplant for the thrombosis showed a worse outcome versus the non-transplant patients. And the better overall survival was seen with an younger age and shorter interval from the day of diagnosis to the transplant. So this is the pie diagram which shows the transplant outcomes in this study. So the patients who are 86% of patients with a hemolysis showed a better overall survival when compared to that of an underlying bone marrow failure and the thrombosis. So from this pie chart, it showed that patient with a thrombosis has a lesser survival when compared to that of the patients with that hemolysis and the underlying bone marrow failure. The right side is in Kaplan-Meier curve, which showed the survival rate was much better for a patient who had underwent for the MRD donor transplant. So the transplant outcomes where the successful engraftment was seen in 93% of the patient. The graft failure was seen only in 14 patients, that is 6.9. The acute and chronic GVHD was seen in 42% and 28%. The PNH recurrence was seen only in the one patient, that is 0.5%. So another study was EBMT swab study, which is done from 2011 to 2020. Totally of 240 patients comes under this study. So 3-year overall survival was 79% according to this study. If it is an early transplant, that is from the diagnosis to the transplant, if it is less than 1 year, the patient had a better overall survival. So there's no significant impact was seen in the regimen type of comorbidity, graft source, or GVHD prophylaxis which is used. And the regimen which is used, the RIC or MAC, doesn't have much significant difference in outcomes. The infection and GVHD was a major cause of mortality in these patients. So according to this study, complement inhibitors is the standard care. But if the options, that is the complement inhibitors, is unavailable, or the patient who are in severe cases, the bone marrow transplant was the indication for treatment. This is the inference of the study. So the transplant outcomes in 3-year overall survival, the sibling donor, it is 86% when compared to that of matched, unrelated and mismatched, which was 68 and 62%. The distribution of the donor types where the MSD was 46.7 and not 37%, and then mismatched unrelated were 2.9%, mismatched haploidentical was 3.3%. So the rate of GVHD grade 2 to grade 4 acute GVHD was more for the mismatched unrelated, which is 28%, for the matched sibling 12 and 10% for the matched unrelated alone. So Piffet et al., he done a large study which is done in 211 patients in 1970 to 2007, found the thromboembolism is a contraindication to the bone marrow transplant. And then Claudia et al., which is another study, they found that GVHD and the TMA was linked to an endothelial injury and the complement activation. So the complement inhibitors, if we use, may improve the transplant outcomes. So they found that if the complement inhibitors used prior to the transplant, it has better outcomes. So in the Nakamura et al., he enclosed 42 PNH cases treated with the transplant, showed an overall survival which has a negative impact in the transfusion burden before the transplant. The Cooper et al. Had another study which is done in 2019 showed that reduced intensive conditioning regimen had a better donor chimerism and it controls the PNH. But the drawback of the study is it is a retrospective design and it showed an unclear graft failure definitions. So the role of eculizumab in the transplant for the PNH. What is the role of eculizumab was? If it is in short, pre, peri, or post-transplant use, it reduces the risk of thrombosis and the endothelial injury. And it should be, there was various study which showed it can be stopped during the conditioning or until the engraftment it can be given. There is no adverse effect on the engraftment. There is no transplant complication was seen with this eculizumab. And 20% of the PNH clone was there. We can consider the pre-transplant eculizumab. So Desrin et al., he showed that pre-transplant eculizumab, if it is used, it has a better transfusion independence and a sustained engraftment was seen. And then another study, which is done by the Vallet et al., 21 patients were enrolled in the study, showed an overall survival, that is 6-year survival of 67.7%. In this, 95.2% of the people were engrafted successfully and 33% of the patients had an acute GVHD. So from this study, it showed that if you are using the pre-transplant eculizumab, patient will have a better engraftment and the rate of acute GVHD was less. So the transplant in PNH patient were already treated with this eculizumab had successful outcomes. So, and this eculizumab does not interfere with the engraftment. So, what is an usual conditioning regimen which is used for the PNHs? Flu-trio ETG, that is a reducing conditioning regimen which is found to be a safe, effective with alternative to an busulfan-based protocols. And it showed a lesser morbidity and mortality. This trio showed a lower toxicity and better engraftment for a severe aplastic anemia with the PNH, though it does not target on the underlying PNH clones. So, in a patients who are with a severe aplastic anemia with the PNH clone, small PNH clone, if they are undergoing for transplant, the flu-cy ATG remains the standard conditioning regimen. The clone size and if there is a bone marrow cellularity, hypercellular, bone marrow cellularity, these two plays a main role in helping us to guide to choose the conditioning regimen. If it is a larger clones and higher cellularity, we should choose in myeloablative protocols. when compared to that of this trio flu and the ATG. In classic PNH, the true flu is an acceptable conditioning regimen. The fludarabine-based therapy, which showed in reduced toxicity and are well established in classic PNH. So there is no cutoff for the clone size for this true trio versus or the flu side ATG. So the recent trial, this one suggests more than 10% of the clone size favors the trio one. The trio-based conditioning regimen showed a lesser toxicity. The GVHD prophylaxis regimen mainly showed better outcomes with this calcineurin inhibitor, either with an cyclosporin or tacrolimus, which is combined with an methotrexate or MMF. So the overall survival for the unselected PNH patient who undergo the transplant using an HLA matched sibling donor is in range of the 52 to 60%. So monitoring, how we have to monitor a PNH patients. The underlying recommended intervals was 6 to 4 months, at least for 2 years, and increasing to 1 year interval for patients who have a stable PNH clone. In case of an aplastic anemia with a small PNH clone, we have to monitoring should be done annually. So from this, the takeaways are the eculizumab can control the hemolysis and thrombosis, but it is not a curative drug. It needs a lifelong treatment and it's a very costly. The Neisseria meningitis and infection rate was higher with this eculizumab. So patient has to be vaccinated 2 weeks prior to this eculizumab. If the PNH patients, if they have an underlying bone marrow failure, if they have a small clones, they have a good response to the immunosuppressive therapy. And bone marrow transplant, it is needed only in the severe cases. Then allogenic transplant, it is done for the severe bone marrow failure and also in patients who are refractory to the hemolysis, refractory case for refractory hemolysis thrombosis cases for the immunosuppressive therapy. And we should use the flu trio and ATG or the standard conditioning regimen for the PNH. If they have an underlying bone marrow failure, then the conditioning regimen should be flu-ATG. And if we use in pre and post-transplant eculizumab, there is a better engraftment was there, and then acute GVHD incident was low. And the monitoring for the PNH clone, it should be done for every 3 to 6 months for 2 years, and then yearly for a PNH. For the aplastic anemia with an PNH clones, the yearly monitoring to be done for the clone size. Thank you.
Thank you for your presentation. So I would now request Aruna to just say some concluding remarks on this case, and then we'll go ahead with the Q&A.
Thank you, sir. Thank you, Dr. Lakshmi. You have made a very clear presentation on the management of PNH. So a few words about to add on to what you have told. Now, in August 2025 onwards, the drug eculizumab is available in India, marketed by AstraZeneca with a MRP of 99,000, and it is available as a 300 mg vial size. So it's like it is otherwise we used to get the imported drug, but now we can get the drug in cities like Chennai. We can get the drug in 1 or 2 days, or immediately the distributor has the stocks. And according to the literature, ravulizumab may be a better drug in terms of drug administration. Give 1 week in the maintenance phase, making it more patient friendly. And actually, bone marrow transplant is not a usual therapy for a classic hemolytic PNH. And if you see in the literature, most of the time transplant was offered before the year 2000. And after the availability of the complement inhibitors, only the developing countries are reinventing transplants for this disease, whereas the developed countries have completely switched to monoclonal antibodies or the oral drugs. So in this scenario, it was a new experience for us to transfer a patient with PNH. The only encouraging thing was the availability of a equally matched sibling. And she was already, and her disease has evolved over a period of 2 decades. In the initial 10 years, she was having cytopenias, which was controlled with cyclosporin. And in the last 5 to 6 years, she had actually evolved into a classic hemolytic PNH. So there is a possibility that she initially had a aplastic anemia with the PNH clone, which has then evolved into a classic hemolytic PNH. And meanwhile, she also developed diabetes. We don't know whether it is possibly it was triggered by the drugs, including steroids that she has received as a part of PNH treatment. So her transplant, how to condition her was again a challenge. So we had limited literature how to condition her. So after discussing with a few eminent people who have done PNH transplants, so we decided to use triosulfan, fludarabine, and rabbit ATG. And her post-transplant period was complicated with a lot of mucositis that we could meet GVHD prophylaxis. We switched to MMF and we gave her Closporin. So now it's good that she has 100% donor cells, and now it has done relatively well. We were also worried about graft rejection in these patients who are multiply transfused, and these patients may also have hepatitis B and C infection because of the transfusion, transfusion-related hepatitis, transfusion-related viral infections. So one of her reports also mentioned about MDS, her bone marrow report. So actually the red cell related dysplastic features is not what is diagnostic of MDS and PNH because red.
I think we've lost Aruna. Is she there?
Lakshmi can follow up, I guess.
So Lakshmi and Karthik is also there. Let me ask a question. So if you
Yes.
had patient in 2025 September and Aruna is back. So Aruna, I was just asking this question.
Yes, sir.
So if you have this patient in September 2025 and you, through the state government health scheme, you are able to get eculizumab, what would you do?
So it is like now we are having the enzyme replacement for Gaucher's disease through the rare disease program. Rare disease, we are a COE, Center of Excellence. So these still rare diseases, including Gaucher's, are getting enzyme replacement to 50 lakh. So then actually all these resources seem to have a limited availability. So I think there is some internet connectivity issues. I will switch off the video. So there is a capping to the available resources. So in case of a matched sibling donor availability, I would still prefer to take these patients for transplant because we cannot afford lifelong or a long-term complement inhibitor therapy.
Yeah, so if you had a matched sibling donor transplant and you decide to go for transplant, would you still expose this patient to eculizumab for some time before you take up the patient for transplant? If Aruna is not around, Lakshmi or Karthik?
Hello, sir.
Karthik, so if you had a matched sibling and you were taking up for transplant, but you also had exposure to, you had eculizumab available, would you sort of use eculizumab as a bridge to transplant?
No, sir. We will proceed with the transplant directly, I think, sir.
Okay, because I think
Matches, it does not reduce the clone size or.
no,
So,
but I think
Biju,
yeah.
they are justified in because of the dysplasia there and
Yeah.
requiring multiple transfusions.
No, it's not
Uh,
that. I think the data is that, see, for example, if you take up a patient with active hemolysis going on then the thing is you get pigment-related nephropathy, pigment deposition nephropathy, and so the chance of having complications during transplant is probably going to be higher. So if you can sort of stabilize the hemolysis and reduce the urine hemosideриnuria, you may end up having slightly better outcomes following transplant. And I think one of the slides which Dr. Lakshmi
Lakshmi.
presented, in that also, I think one of the studies they had mentioned that pre-exposure to eculizumab actually
increases.
increase the
Better survival.
so, I mean, I understand. I don't think even if the government offers it, it's not going to be lifelong. But if it can be given for some time, it may be a useful tool. Any questions from the audience? You can either put it onto the chat or Q&A. Joseph, you want to ask any questions?
Yeah, so one question was, during we talked about embolism here, and the patient had bleeding during the conditioning and you used OCPs. Would that be a thoughtful decision to use, or would you want to avoid it in a scenario like this?
But you have to repeat the questions. Bleeding and use of
OCPs.
OCP.
OCPs.
Because you've got
So,
PNH with the risk of thrombosis.
So that is something, I mean, I'm just thinking from the management point
Patient
of view
taken
there.
OCPs after the transplant, not during or before the transplant, sir. After the 4 months of transplant only, she's been exposed to the OCPs, not during or before the prior to transplant.
Oh,
Okay, so she continued to have some sort of a
Yes.
menorrhage.
Yes, sir. Yes, sir. From the May only, she started taking the OCPs.
Yeah. So question to Dr. Biju. Is the conditioning, would you want to do trio considering the cost, or you could have managed with cyclophos? Is there anything against using
Yeah, so I
cyclophos?
think it depends upon the marrow. So I would agree if you had a hypercellular marrow, earlier we were actually doing BU-Cy, we would do either flu-BU or flu-trio. If it's an aplastic marrow with PNH, yes, we would do flu-Cy. So I think they are right when you have a hypercellular marrow and with active hemolysis, I would prefer to use something more myeloablative. And then I think it's a toss-up between BU versus trio. BU probably will end up causing more problems. So trio may be a safer option.
So this patient did not have any creat issues, right?
No, sir. She had more of mucositis rather than a renal injury. But now actually we are transplanting another PNH patient who's undergoing a matched unrelated donor transplant. So he had overt hemoglobinuria during conditioning. That now we are not able to give him cyclosporin. We are giving him sirolimus post transplant. So I think that is one of the, as mentioned by Biju sir, if we can access eculizumab in the peri-transplant period, I think the kidneys may be better protected.
Saved there. Yeah. So you are using sirolimus thinking that it will less toxic to the kidneys. Among the evil, choose the lesser of the evil. Okay.
Yes.
So one more question to you. In terms of conditioning protocol, you use 225. Can you just translate the rabbit ATG in terms of 2.5 mg per kg, or how much was the total mg per kg you used there?
So we have used a dose of around 4.5 mg per kg.
Oh, fine. And what about trio? How much was the trio coming in?
So actually, for her, it
3
was,
days.
yes, sir, we have used 10 gram per meter square per
Okay.
day
So
into 3 days.
So Biju, wouldn't this come into a RIC or a
Yeah,
MAC?
so 10 usually qualifies as a RIC, but probably still more myeloablative than a flu-Cy.
Okay. So, and the use of rabbit ATG was allo immunization issues or rejection to be prevented because she was 20, 25, this thing. So, Biju, you have been using equine ATG mostly, or have you switched over to rabbit ATG now?
No, we are for most, I think, except for the THALs, we have switched over fully to rabbit.
Okay. And between grapholon and thymoglobulin, is there any choice or?
So if you look at the data, it is, I think both are equivalent. The only thing is the dose at which they use grapholon, which is usually 60 to 90 milligram per kg, it's very, very expensive. So
Okay,
I
so you
wouldn't
would
want to
prefer
use
to
it.
use.
Yeah. So if you ask me, so there has always been a question, this 4.5, when you use, actually most of the data on this 4.5 is when it's close to the graft. And if you ask some of the dadas of ATG, they will say if you go away from the graft, you should actually go up to 12 to 15. That is the dose that they want because you're going away from the graft. But we use only 4.5. We need to now analyze and see what it is because we think it should be adequate, but we need to analyze. It's not what, if you go to Europe or somewhere and ask them, this is not what they will do. They will at least double the dose.
Yeah. So interestingly, I've got a question from one of my students who was working somewhere else. Today morning was the discussion. Same scenario, a PNH with hemolytic crisis. They had scheduled the ATG on day -3, day -4 onwards. And by the time the 4 doses of Fludara had gone in, with the first dose of ATG, the patient goes into renal failure and almost DIC with platelets dropping, PTA, PTT being prolonged. And creat is rising, went up to a hypotensive crisis. So basically, anaphylaxis to rabbit ATG with hypotension and worsening of renal failure with the DIC. What would be the thinking process here? The possibilities are abandon the continued conditioner transplant or salvage with certain modifications.
So here, I think, we have to say we cannot give any more ATG, definitely. So I would just go ahead. He's already got the flu and the SI, is it?
4 days, no, only 4 days of flu has gone and no sign. It was day -4 now, -3 or -3,
Yeah.
I think. Yeah.
The question is, do they have access to TBI? I would go ahead with 200 or 400 centigrade TBI because even giving cyclophosphamide as pre-transplant is going to be dicey when you have renal failure and that's worsening. If that conditioning had actually got over, I would have considered PTCY post-transplant as a single dose at least for GVHD prophylaxis. But here I would just go ahead with flu TBI and go ahead. The question is, do you want to abandon the transplant at all?
That is.
We don't know the data about what happens when you give fludarabine, how long they're going to be immunosuppressed. I would assume for quite a period of time. And the chance that you will lose this
But
patient.
taking the leave from the flag protocol and from the FCR protocol, wouldn't it be reasonable to say flu 4 days would not be myeloablative and it is going to recover?
It will recover. The question is, when will it recover? That is the problem. I am not sure unless you put in a graft, it is going to recover within 14 days. So the longer it is, and in an Indian scenario, the longer it is fungal infection and bacterial infection is a problem. So, Joseph, there are two questions.
Yeah. I know we must go into that. Yes, I was also looking at it. Yeah, go ahead, Biju, go ahead and read.
So, these are questions for you, Aruna. What would be the choice of conditioning for haplo PNH transplant for classical PNH? If you had to do a haplo for a classical PNH, what would be your choice?
Sir, this scenario for a haplo PNH, definitely. So here it is again a cellular marrow. So it is for a classic hemolytic anemia. If we are proceeding for a haplo transplant, in this I would prefer to give a triosulfan fludarabine in the conditioning protocol and give post-transplant cyclophosphamide. This is what I would prefer, as I would have done for a
Okay.
any cellular marrow. But
So I think
I have not done a
question.
literature review for it,
Yeah,
but
no,
this
I
is what
understand. I understand.
yes, sir.
And I think that's fine. When you have a hypercellular marrow, I would say prefer to use trio, whether it's haplo or the. So the other question, and it comes to what you were saying you would do for an unrelated transplant. Would you use post-transplant cyclophosphamide MMF as GVHD prophylaxis in patients with active hemoglobinuria? Or I would put it the other way, like you said, somebody who's got renal dysfunction already starting off. Would you consider doing PTCY?
So that is one of the choice that we considered when we took up the first patient for transplant, whether we should use post-transplant cyclophosphamide. I think that is especially with cyclosporin and MMF if the kidneys were okay. Otherwise, with post-transplant cyclophosphamide
So let
alone.
me ask you, Aruna, about your patient, where you
Yes.
said that the creat is high. You're planning to give sirolimus instead of cyclosporin. So my worry would be you're giving trio. When you're
Yes.
giving trio, you're going to have 2 weeks of mucositis, which means your sirolimus levels are going to be absolutely rock bottom till that mucositis resolves. So there, the question would be, would you actually consider PTCY followed by sirolimus from day 5? Then you
That
will
would
at
be a
least
better
have
regimen. Yes.
cyclophosphamide on board, which you can still give.
Yes, because as MMF again is a oral drug here, and sirolimus is a oral drug. I think both we had this issue with this ongoing transplant. The sirolimus levels are low, so we are hiking up the dose, but we don't know whether hiking up the dose will help the patient. So
Yeah.
post-transplant cyclophosphamide would be a better choice in this scenario.
So there are 2 other questions on the chat. So exposure to eculizumab can it increase the risk of infection at transplant?
I think that is a good question, sir, because the more we deal or inhibit the complement system, we are going to have more infections with Neisseria-based organisms. So I think we have to be vigilant for it. In this scenario, we may end up using more immunoglobulins post-transplant as to keep the immune system up.
So Divya, I would say yes. Theoretically, there's a risk, but remember, as a prerequisite to using eculizumab, you're actually supposed to vaccinate first. So we are hoping that that vaccine, whatever you would have given, will remain on board for some time. It's always the capsulated organisms which is at a higher risk, and you're going to put them on penicillin prophylaxis afterwards. So it may take care, but yes, theoretically that risk is there. So the other question is why pneumococcal and H influenza are not recommended in vaccination prior to eculizumab. I think the answer is from the previous studies when they gave eculizumab. Even Neisseria meningitis was not there originally. If you look at the original studies, it is when they found a higher incidence that this came in as a standard vaccination before the eculizumab. So we learn from experience, we learn from previous good or bad experience, and the vaccination actually is based upon that. Are there any other questions? No, I think,
Sir,
yeah. So, Joseph, you want to give
sir,
some conclusion remarks? I think we are just 1 hour on the
sir,
dot.
one more doubt, sir. So how
Yeah,
often
good.
you will monitor the PNH clone post-transplant, sir? What
Yeah,
will
so
be
that
the
is actually one
threshold
question I wanted to ask.
prompt intervention? Okay.
See, I mean, we would do it at least once in 2 to 3 months along with the chimerism to see what is happening. So, Aruna, did you do that in your first patient?
So we have done once, and there was no the PNH clone detected. So we have done only once.
And
We have
what is
just
the original PNH clone?
she had more than 80%
Okay, so that's very
PNH
good.
clone in the granulocytes. Yes, sir. The
That's very good
90%,
reduction.
sir. 80
90%.
Okay, so that's very good reduction. Yes, but if you ask me, is that sensitive in terms of picking up rejection? I don't think so.
Correct. So my question is, Biju, if the chimerism is fine, is there a rationale to do
So
clone monitoring?
so people do no. So I know people do it when there is an unexpected drop in hemoglobin,
Correct.
when there's anything to suggest hemolysis.
When will you intervene, sir? Look, threshold for intervention, either how to predict the relapse, sir, either mixed
No,
chimerism or PNH clone in
I
subclinically.
would go more by chimerism if you have a sensitive chimerism. That I think is important. And the intervention would basically be rapid tapering of immunosuppression in case you find that your chimerism is going down. When your chimerism drops, of course, you would definitely like to look at the PNH again and see whether the clone size is going up. That gives you more the reason for intervening in terms of reduction in immunosuppression, and both the chimerism and the clone size then sort of become markers in terms of looking at the response.
Biju, paraphrasing the same question you asked to Aruna, if you were to decide on a transplant in a hemolytic PNH, would you choose eculizumab or you would still transplant it?
So I would have a conversation with the patient. Because the question, and like Aruna said, it's still costly when you're looking at lifelong eculizumab. So I would definitely push the eculizumab and give 6 months to try and reduce the hemolysis, make the patient more stable. But ultimately, if it was a MATSIB, I would 100% take up for transplant. If it was a haploidentical donor, then we have to have a
Plus minus.
conversation with the family what they want.
Sure. And also, Biju, suppose we may encounter a patient with a borderline creat and we don't want to take our chances with the lesser of the evils. PTCY, would you consider in a sibling transplant a PTCY here?
Yeah, we do that. We do that quite often for our aplastics. So many of our aplastics, what happens is the older ones come, they are on cyclosporin, they come with creat of 2. Now we wait for some time and see whether the creat comes down, but sometimes it doesn't come down. And those patients, we actually do PTCY post-transplant.
Yeah. Is there any possibility of, I mean, I'm just thinking loud, okay, of Fanconi having to be ruled out in a scenario considering it is less than 40 year of patients?
So you would have done it right at the beginning when the patient presented with aplastic anemia.
Plastic,
But
not otherwise.
once you have an acquired PNH, I mean, I know
Unlikely.
people say they have one case report of Fanconi with PNH, but generally both are mutually exclusive in general.
Okay, good.
So in this case, we had our DM senior resident, Dr. Vandana, who was very instrumental in discussing the case with many experts. Now she's a consultant in Caritas at Kerala. So I would
Okay.
like to acknowledge her. Thank you.
I hope she's joined this meeting. Okay, go ahead, Biju, conclude it
Yeah,
off.
all right. So we are on the dot, on the hour. We've had a very good discussion on PNH. Thank you, Dr. Aruna, Dr. Karthik, and Dr. Lakshmi for the presentation and the discussion. It was very enlightening, and I hope the people who joined in, there were roughly close to about 90 participants in this today's session. I hope everybody has learned about PNH, about transplant. Unfortunately, these complement inhibitors are something which a lot of us do not have much personal experience in using, and just because of the cost, hopefully people will come out with generics and then we will have a better hand of how to use them. Over to you, over back to Intas.
Thank you so much, sir. As we come to the end of today's episode of Blood the Life Savior, we extend our heartfelt gratitude to everyone who made this session a success. Our sincere appreciation goes to our eminent faculty from Madras Medical College, Chennai, Dr. Aruna Rajendran ma'am for her insightful summary and conclusion, Dr. Karthik Velvan for leading an engaging discussion, and Dr. Lakshmi Chitra for presenting a thought-provoking case. Your contributions have made this session meaningful and practically relevant for clinicians across specialties. A special thanks to our course directors, Dr. Biju George sir and Dr. M. Joseph John sir, for their constant guidance and for shaping this series into a truly enriching academic platform. Finally, we thank all our viewers for your time and active participation. Your support and feedback inspire us to keep bringing forward new impactful cases in the field of bleeding disorders. We look forward to welcoming you again in the next episode of Blood the Life Savior with yet another unique topic and engaging discussions. Until then, stay inspired and keep learning. Good night and thank you once again. Thank you so much, sir. Thank you, Viju,
Thank
sir. Thank you, Joseph, sir.
Thank you.
Thank you, Aruna, ma'am.
Thank you, sir,
Thank you,
for
sir.
giving us an opportunity. Thank you, sir.
Thank you, ma'am.
Thank you, ma'am.
Vineet?
Thank you.
Yeah, ma'am.
Okay.